Welcome to Module 1. This is the first teaching module of the course where we explain what TCCC, Tactical Combat Casualty Care, is, the preventable killers it aims to address, the 3 phases of care, and the march order of assessment and treatment. In general, we can group combat injuries into 3 groups: the ones who will die no matter what we do, the ones who will live no matter what we do, and the ones who may survive only if given proper care. Most deaths in combat are in the first group. They happen quickly, from wounds that would not be treatable outside a surgical theatre or a hospital trauma bay. Of the survivors, most would be in the second group. But there is a large group with potentially life-threatening injuries that the person next to them could have treated, even without being a surgeon or a medic. It is this last group that TCCC focuses on: the preventable deaths. TCCC is a set of battlefield trauma guidelines built on a simple idea, backed by experience. Simple interventions at the right time save lives, where advanced interventions too late do not. It is built from real combat data, and it has become the standard across modern NATO countries. You can see the effect in the chance of surviving a war wound. Through the 20th century, combat produced about 1 killed for every 4 wounded. With widespread TCCC, that ratio shifted to roughly 1 in 10, and it was, at least in part, these guidelines that moved it. The drugs and the surgical techniques were largely the same. The use of them is what changed. In the units at the forefront of TCCC training, such as the Rangers and Special Forces, preventable battlefield death has been driven close to 0. The lesson: if you can get the casualty to surgery alive, they rarely die. And you do not need to be a medic to save a life. If we look at the causes of preventable death in the largest study of its kind, nearly 4,600 American battlefield deaths from 2001 to 2011, almost 90% died before reaching a treatment facility. Of the deaths judged potentially survivable, roughly 9 in 10 were bleeding to death. So bleeding is, by a wide margin, the #1 preventable killer, and a limb bleed is the easiest to treat. With body armor now covering the trunk, the groin, and the neck, an increasing share of wounds falls on the arms and the legs, the bleeds you can actually reach. After bleeding come airway compromise and tension pneumothorax, in relatively distant second and third places. An interesting 4th place is hypothermia, which rarely kills on its own, but makes everything else worse, and bleeding harder to stop. Studies of battlefield casualties show that hypothermia prevention is the 3rd most frequent life-saving intervention performed, after vascular access and hemorrhage control, which has informed how we've built this course. Of the cases of lethal bleeding, only about 1 in 7 are from a limb. Nearly a 5th are junctional, bleeding from the groin, the armpit, or the base of the neck. Around 2/3 are truncal, meaning inside the chest or abdomen. No tourniquet can reach a truncal bleed. Only supportive measures, such as hypothermia prevention and rapid evacuation to surgery, can really affect their chance of survival. What we largely focus on teaching are the skills that target what the first person on scene can actually treat: compressible bleeds from limbs and junctions. The truncal majority is more problematic, which is why armies push blood forward and race casualties to surgery. It is, however, reasonable to assume that wounds in the current combat climate will increasingly come from shrapnel and fall disproportionately on the arms and legs, which are exposed, while body armor protects the chest and abdomen, and that head wounds will more often be immediately lethal or non-survivable. A central idea in TCCC is that the tactical situation decides the medicine. The same wound is treated differently depending on the tactical picture. During an active firefight, the best medicine is winning the firefight, and good medicine in the wrong moment is bad tactics. This also applies to other situations where you are under direct threat, be it a building fire, a drone threat, or a landslide. Deal with the threat before the medicine. How we do this in practice can be thought of in 3 phases: care under fire, or CUF, tactical field care, or TFC, and tactical evacuation care, or TACEVAC. In the care under fire phase, you and the casualty are still under effective enemy fire or another direct and immediate threat. Your kit is whatever is on you or the casualty, and the best medicine is fire superiority, because winning the firefight protects everyone, including the casualty. In indirect fire or structural collapse, getting into cover serves the same purpose. The priorities here are simple: return fire, stay behind cover, and do not become a casualty yourself. Most important of all, never rush to a casualty. The point where they were injured is likely an exposed point, where any rescuer faces the same danger if they are not careful. If the casualty can move, fight, or help themselves, your job is to instruct them to do so. The only medical treatment in this phase is stopping life-threatening limb bleeding with a tourniquet, placed fast, high, and tight over the uniform. Don't worry, we will come back to the hows and whys. The point is this: you do not assess or treat the airway or anything else. You do not do a head-to-toe, and you do not take vitals. You treat massive bleeds, and you create a safer situation to get to the next steps in treatment. In tactical field care, you are no longer under effective fire or direct threat. You are behind cover, at a casualty collection point, or the threat has been dealt with. A simple field cue tells the two phases apart. If you still have to keep your head down, you are under effective fire. It is still care under fire. The moment you can get your head up and work, you're in tactical field care. Now you have time and more equipment to help the casualty. This is where the march sequence comes in. Reassess the tourniquet, deal with major bleeds, secure the airway, prevent hypothermia, help breathing and chest wounds, manage circulation and shock, assess head injuries, and document. We will come back to the specifics, don't worry, but remember, the danger can always come back. Stay switched on and keep watching your surroundings as you work. Tactical evacuation care, or TACEVAC, is care during movement to a higher level of care, in a vehicle, by air, on a boat, on foot, or by sled, or horse for that matter. The point is that you keep march going. Monitor, reassess, protect what you have already done, and prepare a clean handover. A key observation: movement loosens tourniquets, disturbs dressings, and obstructs airways, so recheck after every move. Here we see the same patient but different priorities. Under fire, we want to win the fight and stop the big bleed. In tactical field care, we work our way through march, and during evacuation, we reassess, keep it going, and prepare to hand over. March, written M-A-H-R-C-H, is the order in which you assess and treat a casualty. Massive bleeding, airway, hypothermia, respiration, circulation, head injury. The previous standard version, spelt M-A-R-C-H and said the same way, puts hypothermia near the end. In this Nordic variant, hypothermia moves up to third. This is because cold blood will not clot, so leaving it for later can undo all the work we have done to improve bleeding, breathing, and circulation. The data also supports this. Hypothermia prevention is the third most frequent life-saving intervention performed on battlefield casualties, after vascular access and hemorrhage control. Again, under fire, you only reach M. In tactical field care, you work the whole sequence and keep cycling back. Think of the phases of care as when and where you treat. March is the order in which you assess and intervene. And to be clear about provenance, MAHRCH is the TCCC-Plus teaching order. The official TCCC sequence remains MARCH, though even there, hypothermia prevention should begin early. The All-Service Member level, or ASM, is the level of knowledge and skill every soldier should reach. Beyond this, your unit may train and authorize you to provide more advanced care: tourniquet conversion, needle decompression, stronger pain relief, and prolonged field care, some of which are taught here. For these and anything else outside your scope, make sure they are within your unit's protocol, or call for a medic, evacuate, or get telemedical support. Let's go over some classic mistakes related to TCCC and the phases of care. Doing medicine under fire instead of winning the firefight. Forgetting that a care under fire tourniquet must be reassessed in the tactical field care and TACEVAC phases. Treating out of order, chasing a minor wound while the massive bleed or the blocked airway is ignored. Note also that the loud injury is not always the lethal one. A person who can scream has enough blood to keep their brain going and a patent airway to scream with, at least for now. And last but not least, don't forget scene safety. Don't go running to a casualty without first assessing the risk of doing so. To recap, TCCC saves lives with simple assessment and treatment in the right order. Bleeding is the #1 preventable killer, and most lethal bleeds are truncal. We target the bleeds we can reach and rush the rest to surgery, ideally giving transfusions to keep them alive until then. Phase decides approach, march decides order. Know your limits and get help when you can, and don't become another casualty.